Hi, I'm Tammy Fletcher. I'm a licensed marriage and family therapist, and I specialize in treating body-focused repetitive behaviors, or BFRBs. Those behaviors can include chronic skin picking, hair pulling, nail biting. I've treated BFRBs for about 15 years, so hundreds of clients and thousands of hours of treatment time. When I started in my practice working with BFRBs, there was not a lot of information available. Like many people, I relied heavily on the Trichotillomania Learning Center, now called the TLC Foundation for Body Focused Repetitive Behaviors. I'll leave a link to them in the description bar below. TLC was and still is, in my opinion, the best resource anywhere for patients, parents, clinicians, loved ones, anyone who wants information and support in dealing with BFRBs. A lot has changed over the years. Organizations like the TLC Foundation have engaged in research, studying the efficacy of medications, response prevention, habit reversal training, supplements like NAC, and types of therapy. With new knowledge came new approaches to treatment. I learned the most from listening to my own clients and what it's like for them. I can't speak for all therapists who work with BFRBs, but I'd like to share some of the ways my practice has changed over the years. Abstinence has now become damage control. While ending the chronic behavior is obviously always the goal in therapy, I don't ask my patients to stop on day one. In my experience, that did not work. BFRBs are stubborn, and it's likely the client has been engaged in the behavior for years, and it sets them up to fail, to send them home after the first meeting and say, all right, I don't want you to do this anymore, starting now. What I have found works is moving forward in baby steps. Even resisting an urge for 5 minutes is a huge win for some people. Set them up to succeed and definitely notice baby steps. Another thing that works is focusing on thoughts. I'm a cognitive behavioral therapist, so I want to dismantle the urges. I will ask, what does the urge sound like? What is it telling you? To get at what thoughts are coming up around the behavior. Often the answer is, I don't know. I'm not thinking about anything when I do it. So we work on mindfulness. We pay attention on purpose. We identify distorted thought patterns and notice the thoughts until we understand the urges well enough to begin to take them apart, challenge them, and replace them with preferred ways of thinking. Another thing I learned is that despite wanting the BFRB behavior to end, there may be a part of the client that just doesn't want to stop. Generally, the behavior started for a reason. Maybe it helped calm the brain enough to focus, or it alleviated some stress or boredom. Every client I have has heard me talk on and on about brain chemicals that might be released during the behavior, and how zoning out, which often happens during a BFRB episode, can actually be something that the brain needs in that moment. There may be other ways in which the behavior, although unwanted and even unhealthy, provides some kind of benefit for the person. There may be some degree of satisfaction that the client experiences when they're engaging in a body-focused repetitive behavior. Most clients have expressed that to me. Maybe it's getting something out of a clogged pore, or pulling out that one hair that feels completely different from the others. Clients have described a kind of satisfying popping sensation when they pull out a hair. Sometimes the BFRB feels good to the person in some way. I don't argue with that. What I do is help them look for other things that feel good or interesting or satisfying. Another tool that works is called SCAMP, and that stands for sensory, cognitive, affective, motoric, and place. SCAMP can be an effective way to understand the behavior and to come up with a unique plan for each person. On the surface, it helps to identify tools and strategies that might help reduce the BFRB. It also allows the client to share about which strategies did not work, and each section leads to a deeper discussion of what the person is thinking, feeling, or doing when the behavior occurs. It's not unusual at all for me to spend a full session or even longer on each of those 5 components of SCAMP. Next, I found that I changed the way that I ask clients to monitor the behavior on their own. Many clients find that keeping track of the behavior on a sheet or a journal or an app can lead to shame and frustration. I don't want my clients to feel that way. Some love journaling their symptoms and behaviors and becoming aware of how many times a day they might pull out their eyelashes. But other people are already very painfully aware of how often they do it. Those people might need different kinds of tools. Meet them where they are and be creative together. Next, I've had to rethink my entire ABC approach. The ABC approach, I think, is probably used by many therapists. It helps us break down the behavior, and it goes like this. I rate the spot A, B, or C. An A is something that anybody would want to take care of, whether they have a BFRB or not, like a large whitehead on the end of your nose right before a job interview, or a 3-inch hair sprouting out of your eyebrow. Most people would want to take care of those things. I understand that. That's grooming. I do want people to be as sanitary as possible, using clean hands, maybe sanitized tweezers, hot compress, those kinds of things, but I don't ask people to leave an A alone, but to be careful when they take care of it. Okay, a B means that there's a blemish or maybe a hair that's coarser than the others or gray hair, but a B should be left alone, but we mess with them anyway, and that can make the whole thing worse. A C is when there's nothing there, but the person actually creates it, like picking at their skin until they open a wound and then it scabs over and then they have the scab to pick at. I still find this way of looking at the behavior to be a helpful tool. But what I learned is that what I might call a B, a person with a BFRB might call an A. Something that brings anxiety, something they can't stop thinking about, something their minds react to as if it were a genuine emergency. I learned this directly from my clients. I might say, so if there's really nothing there, I want you to find a fidget or distract yourself or do deep breathing. And they respond, Tammy, you don't get it. It's not a B to me. Even though I can hear what you're saying and I understand it logically, when the urge hits me, everything feels like an A, and I have to do something about it. This really brought home to me the idea about perception being so subjective and the ways urges can be so incredibly powerful. They feel what they feel. The client's perception is true for them, at least right now. So start there. Circle back around to examining the thoughts and go over all the great tools that we do have for them to use. Help them understand that a perception change can be possible and that urges can get quieter. Give them hope and be sure to celebrate every baby step. Those are some of the things I've learned over the years, and I hope you find this helpful. I'll leave a little bit in the description bar below to follow up on some things I mentioned, and don't hesitate to let me know in the comments below if you have a question or a suggestion or something that you've tried that worked.